Okay, our session today is going to be a 91B18 Delta, the infant medic. The concept for this started actually several years ago. I'll get to that in a minute. I want to start with our two guests today, Sergeants First Class, Patrick Buckles and Michael Jones. Should any ill fate befall me in the next 48 hours while we're here, don't call the hospital or the ambulance. Find one of these two gentlemen and don't let anybody else touch me till they say it's okay. Yeah.
I'm an ordained minister now.
It's good to know my brothers are as sick as they ever were. What you see up here is what I sent to John Joyce at the beginning of the year. I am from Chapter 48 in Southern California. He came over to talk with us about the collaboration on the conference. After he told us what it would need for volunteers and everything else, I went up to him and I said, you know, John, someone should put on a session about medics. I've never seen one, and I really think it's about time we address it. And he said, well, not bad, shoot me a note. And I shot him those bullet points. Let's see if we could put something together. He came back a month later, and of course, don't ever say someone should, because that finger comes right back. So he said, run with it. So our concept was to obviously create camaraderie. And I can just tell you, over the last 5 months, the camaraderie has been outstanding. Because we put out a notice in our newsletter to the medics, and I think many of you have seen that, saying that if you have a story, you have pictures, forward them to me. I'm going to be doing a presentation here, and I want to tell you stories. Now, we're not supposed to ever admit in Special Forces that we bit off more than we can chew, because we're supposed to be able to chew and spit out anything. Once I started working with all of them on these topics, I realized I had a mouthful. I could take any one of those bullet points and make them a full day's presentation. I received input from brother medics around the world. It would start off, I would get an email with a couple pictures. In some cases, it would be 1 or 2 lines. I was here, there. Here's what I got. The longest one was 11 pages, small type. Quite a story. He had a memory that of all the things I could not have ever recalled, but as I went through it, I went, oh my goodness, it's like an autobiography of my life. I can't believe this. So I have to acknowledge that what you're about to see, the slides and some of the stories, clearly are not mine. They're shared between the Brotherhood. Just to give you some background, and from my perspective, I was in 91B from 71 to 79, initially with the 5th, later on with the 12th. And as the bullet point up here points out, what did you do afterwards? I was one of those that went on, became a physician assistant. That took me into a career in clinical research. Clinical research, you may not know it by name, but you see it every day on TV. We're the people that do the clinical trials that get new drugs and medical devices approved. So when you see the commercial, it says, doctor tested, here's the results. I'm one of those people that were involved. When you see all the subprint afterwards of all the side effects on the drugs, those come out of the studies that we do. So that was my history. Now, as we go into this, knowing my history of being in medical research, several years ago I was at a conference up in Washington, and it was on medical devices. What's in the pipeline of new medical devices being tested? The Sonic Eye was being presented, and it was being presented under the Department of Defense contract. That is an ultra machine, okay? You can do ultrasound with that. See that little screen? And then, of course, the picture that came after, which I now put together, showed this is how it could be used in the field. And as I sat in the audience like you were today, I started clicking, oh my God, what kind of equipment do these guys have to work with, or will they have to work with someday in the future? And then it's not only the equipment, how do you train up on technology like that and how fast it's got to be training? Well, that is what got it. I sat on that thing for the last 2 or 3 years, and that's at the beginning of this year when I talked to John and said, let's do something on medics. I am dying to find out what these guys are working with, what they're learning, and how they're pulling it off. Now, my challenge was I had zero connection, obviously, with Fort Bragg anymore. And fortunately, our national president, Kevin, when I emailed him and said, we're going to run with the concept, can you connect me with anybody? And yes, within weeks, he had connected me with Fort Bragg. And it was Fort Bragg that signed off on their presence here today. That was the good news. That was about 5 months ago. And then they told me the authorization would start up the line. So every month I would check in, and meanwhile I was working with the 2 gentlemen on the presentation. How are we doing? Major, colonel, just kept on creeping up that line. As of this past week, Tuesday, I'm still sweating bullets. I have no speakers. Wednesday morning, I get an email with a letter attached, signed by a brigadier general at SOCOM, saying it's a go. So these guys had to grab their stuff, make their plans, and be here. Nothing's changed in the military. Before I get into the training and the transition off to these guys, I'm going to give you the side of the story of the 91Bs. How many 91Bs do we have in here? 1, 2, oh, good. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Wonderful. How many of you transitioned into the medical field afterwards? Okay, less than half. And talking with some of my colleagues, that was about it. You know, about half of us took what we learned in there and quantumed up the line in medical field. The other half said, I did my part, I am done. It was an interesting story, but I'm done with that. Are there any 18 Deltas in here? Oh, well, put your hand down, Patrick. Great, that is wonderful. It was about the 80s when they transitioned Bs to Deltas. I don't know the exact date, kind of deal. Now, one of the bullet points I pointed out to you was, what did you do with that medical training you got afterwards? And again, we now know half did something and half went on other parts of life. Well, as all this information in the last 4 or 5 months has been coming in from people around the world with their pictures and their stories, a couple of them just leapt out at me. This particular one was like reading a Hollywood script. I said, this is a movie, nobody's going to believe it. But the more I delved into it, it was true. What you see here is young Buck Sergeant Richard Carmona. This is 1970. He's being awarded his Purple Heart and Bronze Star. That's the picture. What you don't know about the background on that picture is he was a dropout of high school in Harlem when he was 16 years old. In '67, when he was old enough, he enlisted in the military. He took a GED test, and after 3 years, worked his way into SF. He had the intellect. That was not the issue. And he had to find motivation. There you see him getting his award. After getting out, he went back to school immediately, picked up an associate degree, a baccalaureate degree, got accepted into medical school. Here he is several decades later. He's Dr. Carmona, trauma surgeon. And when I talked to him, and just so you know the scenario, after the gentlemen would send me in their stories and pictures, we communicate through email for a period of time. And then I always wanted to have a one-on-one conversation. And those conversations were absolutely fantastic. Some cases I opened up old wounds. Others I healed them, I believe. One of them asked me what I charge for the psychological consultation. But it was a good catharsis for all of us. In talking with Richard, I said, Richard, I went in and I looked at your background. It's phenomenal, and the story's not complete here. And I said, it says that you graduated med school in 3 years instead of 4. And he said, yeah, that's true. And that you were #1 in your class. That's true. I said, why and how? Simple. I applied to all my SF training. When I got there, I had a mission, I had objectives, I had motivation, and he said one thing I had that was different than all my other students in the class. They had all gone matriculated through the educational system up the line into med school. They knew nothing about real life. And he said, I knew a lot about real life and death. And he said, I was on a mission. It didn't stop as trauma surgeon. This is Richard Kimona. He was our 17th Surgeon General. And if you had never heard his name before, which I had not, you know of his work because he's the one that championed the second-hand smoke initiatives and the harm that it could do. It would be nice if the casino got word of that after all these years. Now, in talking with Richard, and he said that his real-life experiences versus the other students, and he said in some cases the professors. He said the best example I had, he said, of my own personal ego was when I was in the tropical disease classes, and a professor was pontificating about the different kinds of bugs you could have in the world. He was talking about malaria, and I asked him, yes, Richard? Have you ever seen, diagnosed, and treated a case of malaria? Well, no, I haven't. I have. He said a little while later in the hour, he said he's talking about schistosomiasis. His hand goes up. The professor looks at him. Yes, Richard. Have you ever seen, diagnosed, and treated a case of schistosomiasis? No, Richard, I haven't. I have. Now, in addition to going on to become surgeon generals, what I learned is the different things an SF medic is qualified for. One of the brothers sent me the note with a couple of pictures, R.J. Casey. And in addition to being a medic, in this case he was an 18 Delta, he was also scuba qualified. After he got out, he started his own business as a consultant to the movie industry and other industries that had strange uses for medics. Here he's seen when they started the SpaceX projects, and they were working with their astronauts to train them. They couldn't just say, here's what happens on a ground landing, here's what happens in a water landing. They had to actually go through all these. And here he was in the water with one of their astronauts, assuring the astronaut that should you land in the water, I will be there to scoop you out personally. So they practiced and rehearsed them jumping in and him pulling them out. He told me that he also has worked on numerous movies, and he said he would love to be here to talk about some of this stuff, but the next day he was taking off to Prague. He was going to be working on the set of Extraction 2 for Netflix. And he said every time he's called onto the set, he talks to the producers and the directors and said, well, what is it you're going to be doing? That's going to tell me what I need to bring in my medical team and my rescue team. And he said, well, what could go wrong? We're going to be in the Czech mountains. We're going to have a train moving through the mountains, and we're going to land a helicopter on it while it's moving. What could go wrong? And he said, I started listing off, well, I need extrication equipment, I need rappelling equipment, I need. And he said, all from SF. He said, I got it wired. In a case, what else could a SF medic do afterwards? In case you didn't realize, Barry Sadler was a medic. He started writing his songs when he was in the hospital recuperating from wounds from Vietnam. Other examples of how an SF medic can be used afterwards. One story was medical services officer on a military sea lift command, which is the new term for what used to be merchant marines. And it was explained to me that running a medical facility on one of those vessels and a group of vessels in the South China Sea is like being a medic on an A site. You're all by yourself. You got to figure it out. The best you could do is radio into somebody to help walk you through it. Or you could be a counter-terrorist member or a rail marshal. I said, I'd never heard of it. And he said, well, post 9/11, the government commissioned the RAND Corporation to do a study. They said, well, we have to admit we were caught off guard about airplanes going into buildings. What about trains? What about vessels coming into a harbor? Where could they get us next? So at the end of it, RAND Corporation reported back that, do you realize that all our train systems go through the heart of all our major cities? And if you were to derail one of those trains loaded with explosives, it would be in the poorest part of town where today they store all the petrochemicals and other chemicals in that city. Can you imagine the devastation? We would take out half of one of our major cities. So they developed a strike force that in the case they ever got the call that somebody had hijacked the train, that strike force would go in to neutralize. In addition, we've all heard the old term of air marshals. They had rail marshals. I had never heard of it. So he said, there we were, riding the trains, looking like the average Joe citizen, but yes, we were fully armed. Or you could be a security medic at a gold mine in West Africa. And what I found out here is they're opening now a lot of the old gold mines that they thought were non-productive, but under new technology, they're going back in and opening them up. They need medical coverage, and this is in West Africa, not in the best areas. They don't just need a medic. They need somebody who can also point that barrel down range and know where the muzzle should go in an emergency, because gold mines are considered hostile environments. But after talking, and that was one gentleman's story, he said this at the end: there's nothing I've done in my life that was as interesting, exciting, and satisfying as being an 18 Delta on an A team. This, I know, is illegible. It's a letter that I was given when they started me in the medical program. After finishing phase 1, we all remember being called in and asked, what is it you want to specialize in? What I found out in talking to so many of my brothers is that there was probably a majority who did not want to be the medic. I was certainly one of those. When they called me in that day, and he said, what do you want to be? I said, an engineer. I'm going to build bridges. I'm going to blow them up. This is cool stuff. He said, you're going to be a medic. Oh, no. You can't make me do that. Right. I said, no, seriously, I can't blood, guts. It would not be cool for the team medic to be puking in a guy's wound. That just would not be acceptable, and that's what would happen. So he finally said, how about this? I'm going to give you a letter. We're going to put it in your file. And it says you're going to go off to medical training. And after 2 weeks, I'm going to call you back in here, and you're going to make the final decision. If you don't like it, you'll be cycled into the next engineer class. So my name's on it. Put your John Henry on it, too. And I did. And I walked out shaking my head, and I thought, oh, darn it. Well, I started that course. 2 weeks later, he called me back in, said, what's your decision? I said, there's no way in hell you're getting me out of this. In 2 weeks, as you know, you had seen and done so much more than I ever thought I would ever see or do. I just remember sitting in the class in the second week, and after talking about all the different IVs and what types you would give for what situations, they roll in that cart in the afternoon and said, gentlemen, roll up your sleeves. It was the old see one, do one, teach one. You're going to start an IV on that gentleman next to you, and you're going to do a really good job on it. because after you're done, he's going to do that to you. So here was the course outline. Back in the day, it was 32 weeks long. 7 weeks basic at Fort Bragg, off to Fort Sam Houston for another 10 weeks, then 7 weeks of rotation, and then finally back to Fort Bragg for the culmination of advanced medical surgical. This is a picture one of the brothers sent me of one of the cadre teams in the day. I don't know about you. They look pretty jolly here, but all I can tell you is in reality in the class, they were hard asses. When you walked in there, they expected you to pay attention. And they were never hesitant about if you gazed off for a few minutes and say, listen, young man, you never want to be in the field and someday say, I wish I had paid more attention to that class that day. He said, you're going to be taking care of people. Pay attention. Now, of all those guys, in talking to some of my colleagues, one name came up in particular, and that was Robert L. Scully. He was one of the teachers. I don't know if any of you had him. That man, he had eyes of steel. He walked upright. This guy was a picture book out of an SF Photoshop. Anything he said, you knew you had to listen. He just had that total commanding presence. Now, we knew he had been to Vietnam. We knew he had been wounded. We never knew the extent or anything else. And, of course, he never talked about it like most. What I found out years later was that he was on FOB-4, August 23rd, 1968. For those who know the story, it was completely overrun. It was the highest casualty loss of SF at that time, 17 KIA SF members in one evening. During the course of that evening, he was seen running about, tending to the wounded, and of course engaging in counter activities with the sappers. However, sometime in the course of the evening, a hand grenade went off near him, took off part of his cranial vault. I didn't know it at the time, but the man standing before me now had a steel plate. It took him 2 years to learn to talk again, but he was now one of our instructors. We just knew we had to listen. That wasn't his end either. He went on to become an Army PA, and he must have done well there because their top graduate now receives the award, the Robert L. Scully Award. See one, do one, teach one. Yeah, IVs, injections, and nasal gastric tubes, whatever it was, you did it to them, they did it to you, and you're right. You really, really tried hard to get it right. After that basic 7 weeks, it was out to Fort Sam Houston. Here's just one of the class pictures. Tom Derosia sent me this. Tom, by the way, is communicating with me, and I finally realized he's in Thailand. Heard about this session through our little bulletin and sent me his pictures. Now, what could go wrong when you send a group of young buck sergeants and spec 4s to Fort Sam Houston, the most pacifist post in the nation? The rumors are true. Several times the commander of Fort Sam contacted SOCOM and said, if you don't find a way to settle down these young bucks, we're closing the program down here because it's ruining the post.
We were always down at 91 Alpha Lane.
Yeah. Yeah, that, for those who don't know, there was a big whack training area down there. As part of that training at Fort Sam, in addition to all the day-long classes, you could be running out in formation at lunch. And of course, we always had to set the example at Fort Sam, which meant you double time in your SF shuffle. And you'd be running down the road in the formation, and of course, all of a sudden, a person would come running out, quick, quick, help, there's been an accident. And then your name would be called off. Derosia to Caesar, go see what they need. And of course, it was our instructors with all these staged accidents. Whether somebody fell off a roof, was climbing a ladder and fell. Somehow, it's hard to see because these are old dark slides. old, or a femoral bleed. And while you're trying to take care of these patients, there are actors are screaming, yelling, and rolling around. To say nothing of all the instructors sitting there checking off each little thing. Did you do it right? Did you do it wrong? What could you have thought of? And you just see on the right-hand side, it's supposed to be an amputee. You got all your IVs running. You think you got it under control, and all of a sudden the instructor yells out, his blood pressure just dropped to 60/0. What are you going to do? And you better have had a thought. Following Fort Sam, was off to on-the-job training. We were all cycled off to different hospitals, military hospitals around the country in small groups. There you got to rotate the different departments. As for myself, Friday and Saturday nights were spent sitting on a stool in the ER suturing for 8 or 10 hours on the thing. What better practice than that? Or you could have been up in surgery, assisting in surgery. Great stuff. And then, of course, there was the one that almost put me over the edge. I went up to OB one night, and the doctor said, follow me. Sit in that chair. I was on the working end of a delivery. I had never seen one. I had read about it. They had told me about it. And he says, you're going to be the one to catch. And it's a good thing that the patient couldn't see me. My eyes were bigger than silver dollars. It's a good thing I was wearing a mask, because my jaw started to drop down to here as things were proceeding. So that mask held me in there. But I never forgot that one. Following that, we came back to Fort Bragg, and that was advanced med surge. It's blacked out to protect the innocent. This picture was never taken. You do not see it at the moment. It's because it was forbidden to take pictures at this time. And of course, what honest, respectful SF medic would ever disrespect an order and take a picture? So you do not see this, but this was part of our advanced training. And there he is, Don. That surgeon over there on the right-hand side is one of my chapter members, Don. So that's him being the surgeon. And what you got to learn working in a 5-man team, you were the surgeon, the assistant surgeon, the anesthesiologist, the circulating nurse, or the scrub nurse. And each time you did a procedure, you rotated that. So you got to master each one. You kept taking turns each time you had your surgical procedures. If you look down there in the lower right-hand corner, that's one of us calculating the body weight of the patient to give the proper dose, keep them sedated during the procedure. And it's the old-fashioned way. It's with ether. You'll find out they don't do that anymore. Our training ended with this, the oral boards. This statement up here is a quote that I will read from one of the letters I got. The oral boards were the very last hurdle. They were held in a theater with a podium centered near the front of the stage. A single light shone on the podium, spotlighting the student like the hot lights on an interrogation room. The front row of the audience section was taken up with our instructors, MDs, pharmacists, veterinarians, laboratory scientists, and so on. The questions were far-ranging, some scientific and others situational problems. I asked the instructors afterwards why it was set up in such a high-pressure test. Surely they could assess our knowledge in a less stressful way. His answer was illuminating. We expect you to make rapid life and death decisions while your own life is in danger. We need to know you can think under pressure. Following graduation, you had a little red book. I still carry that. That was part of the cover. And depending what your role was, you got a little green bag like that, an M3 bag. And you got to learn to do everything you could out of that little M3 bag. Many of us went on to situations like this, A-team sites throughout Vietnam. This picture was from a cover of Life magazine. I'm less interested in the two figures in the front. Off on the right-hand side there's a little baggy old building. That is the dispensary of, again, one of my chapter brothers, Bok Si Howe over there. This is Bok Si Howe in the field. He is attending to a wound from a soda can booby trap that was set up with a tripwire. Nowadays, you don't use the word booby trap. They're all called IEDs. You saw that medical training at Fort Sam, situations that happen and all of a sudden you're dumped into them. You can see here on the left-hand side, it's not about a surgical sterile field. It's about, I got to save that foot. On the right-hand side, the other role of the medic was teacher. Make sure the indigenous forces understood what you do, how to do it, and they could back you up at all times. And if you got a real treat at your dispensary, Colonel Maggie may have even stopped in the day to check to see how our boys were doing. Yes, and people forget. An SF medic is airborne, which means you hump it in or fly it in. Yes, that is yours truly. You can see below my reserve chute is an M3 bag. It just happens to be that one down here. The bulging pockets on the side of that rucksack, yeah, that's D5W and ringers packed in there along with everything else you took in. You had to take it all with you. In the left-hand corner here is Russ Mann. This is 1967. He's a young buck sergeant. He's off working with indigenous personnel, and you could see he's doing his dental work. People forget, we were not only the doctor, the nurse on the team, we were the pathologist, the lab technician, the veterinarian, and the dentist. This is him years later in '92. He couldn't stay out of it in the reserves. He's still deployed with stuff. And there he is in Thailand, using the stuff he learned, treating a monk. This came in from Peter Becker. We're now in 1988, and we have an 18 Delta. Things haven't changed. He's now, for us at least, he's in Kenya working with his counterparts. In the slide on the left-hand side, you can see a counterpart in his uniform. And in the back there, you could see the indigenous forces. On the right-hand side, he's kind of stuck in the middle there, sitting down. He's doing his veterinarian work for the village people. Not those village people. He told me, I was quite impressed with this one. He said the procedure itself really was routine for him. That wasn't an issue to be debriding, cleaning, and sewing it up. He said what really got him was what you can't see in the picture, was the young patient's friends, the ones that had the spears and the machetes on their belts. And he said that was the most intimidating setting he had ever worked in. So that's history. That's where 91Bs were, and that's some of it. And hopefully after today, some of you will shoot me more stories and more pictures, because I've been asked to do a write-up for our newsletter. It'll probably be several parts. SF Medic then, now, and what's happened in between. So if you haven't sent something to me already, please do. And with that, I'm going to turn it over to my young counterparts. I've had the pleasure with dealing them and going through and learning, and my mind was going like this. One of the things I found most exciting, I showed you at the very beginning, the sonic eye that I saw several years ago being developed under a DOD development stuff. And at that time, I wondered what would it be like. One of the slides I received from the gentleman, lo and behold, here's that device. They've got it, and they're learning how to use it. And with that, Mike, I'm turning it over to you.
Good evening. Sergeant First Class Jones, came from 7th Group, so grew up my whole time there. I use grow up very loosely.
Closer to the mic, please.
Sorry, is that better? Yeah, so I grew up down there. Like I said, I use grow up very loosely because I don't think I've achieved that yet. Got about 2 years Afghanistan, and then moved over to our crisis response force. And then I got to go all around Central South America, and then moved over. I was actually an instructor with Range 37, so I was a sniper instructor there. And then to do my 4th year, I asked if I could go over to the med schoolhouse, which is my true passion. And they were like, "Yeah, sure, go ahead." And so the SWIC CSM was an old 7th Group guy, so it helps out, who we know. Yes, we'll get started here. All right, so we're kind of broken down now into 2 parts for the med course. Year-long total, and the first part is SOCM, and the second part, which Pat will talk about, will be SFMS. First part's 9 months, and this is where we take, so the 91Bs changed to 68 whiskeys. So when they go through, they still go through down at Fort Sam, and that's where our conventional 68 whiskeys will come from. And once these guys get assigned, either 160th, Ranger Battalion, Civil Affairs, PSYOPs, Navy Corpsmen, and even some of our approved foreign allied medics come through, they'll come through SOCM. So they'll go through SOCM, pretty much broken down to 8 sections, and once they graduate, they'll get a skill identifier. So they'll be 68 whiskey 1s, and that allows them to serve in a special operations organization after that. And plus our 18 deltas that are going through as well. So first section we line up. What we'll notice, the great thing about the med course is we've adapted. We've really reached out to our civilian counterparts. We kind of have the best of both worlds. Our weapons guys, our engineers, and all this stuff. Our weapons guys are kind of pigeonholed with what is in the Army inventory. For the medicine, it used to be kind of civilian ran. They gave us. They're like, "Hey, you need to start trying this." And then the good thing that came out of if you can say it's a good thing, the long war is we kind of flipped that around. So now TXA, whole blood, everything getting pushed back. We started that now. We're kind of sending it back to the civilians. So we have a good partnership with our civilian counterparts right now. So you'll see a lot of stuff that's really civilian associated. So the first block they go to, National Registry, they become EMTBs. 26-day course right now. We are the highest pass rate of any school in the nation. So like the colleges that are offering EMTB and things like that, we have the highest pass rate by far, and we get it done in 26 days, right? Just with the quality and caliber of students that we get. This also gets them in the door. So toward the end, they'll still go on a rotation, but now instead of military treatment facilities, we'll go to civilian facilities. So now with this EMTB, they got a civilian licensure, so that kind of gets them in the door there. So now they can start putting hands on patients and going from there. So the next part, it's actually 2 parts, but I kind of combine them together because they work well together. Clinical medicine and clinical fundamentals. This is the part where you really get your butt kicked. The month-long course, you're getting pretty much 2 college semesters of anatomy and physiology in 26 days. So we talk about it. We got the cadavers and everything there. We've teamed up with the colleges. We probably have 5 different cadavers now. And I remember I went through the course in 06. We had 2, and they looked like beef jerky. I mean, it was the old school. We would do our pen test, and you could go through and you could see where the pen in each muscle was, and you're like, okay, I need to know this because there's going to be a test question on this. And now we have the lightly embalmed. I mean, they're flexible, pliable. We can move them around. We can do everything with them. So they've really come a long way. In the colleges, they'll teach classes there at night, but I think we have 5 now. So really, really helps out a lot with that. And then they roll over to their clinical fundamentals, and that's where they start, putting everything, all their pathophysiology, their pharmacology, all that great stuff. And then we actually send the students out in the mornings. They'll usually go to the like Clark Clinic, local clinics, and they'll help out with sick call, things like that, so they can start getting patient contacts, start working on their SOAP notes, just starting, that patient interview, patient exam, all that great stuff. Then we move on to Trauma 1, and this is where once again, now we're starting to get a little more hands-on. We're out of the classroom portion. Still learning. We knock out all of our AHA stuff. So they'll leave here with ACLS, PEP, they're CPR qualified, all that great stuff. BLS is already done. We start learning innovations here, or their med math, and then talking about the ultrasound. This is where they first get their ultrasound training as well. Go ahead, sir.
Can you take some of these acronyms that you throw around and kind of trot them out a little bit?
Abs-
A little slow on the uptake.
Gotcha, yes, sir. I thought I'd done most of those, but I didn't. ACLS, Advanced Cardiac Life Support, running all the codes. PEP is the for pediatrics, so pediatric emergency response. Do I have any more here? No. So then we pick up the ultrasound and kind of a brief overview of it. The big thing we're looking for, we do an EFAST exam. That way, so if patient's down, maybe unconscious or whatever, we can check tension pneumos, we can look at the heart, we can look at the spleen, we can look for third spacing of blood, so real quick I can tell in about 2 minutes I can tell if they've got a tension pneumo, heart's okay, spleen's okay, or if they're bleeding inside their abdomen as we pass it on.
So you can do periocardial centesis?
We could do ultrasound guided now if that came to be. Yes, sir. All right, and then toward the end, start going over a little bit, especially with the prevalence here now, do a little post-traumatic stress and suicide prevention and just stress management after events. All right, then we move to trauma 2. Trauma 2, like I said, in my opinion, this is our bread and butter. This is the main, I think, the most important block in the whole schoolhouse that we do. This is our broken down 3 major sections, trauma patient assessment, trauma surgical skills, and then combat trauma management. So trauma patient assessment, we're doing just solo runs on our patient, right? So if I'm operating that day, I'm the patient the next day, and we're out back, we're kitted up, helmet, body armor, all that great stuff, and we're just doing run after run after run. Live IVs, it's usually at the discretion of the instructor. When I went through, I had a guy, he liked top of the foot. He wanted IV started top of the foot, back of the hand. So we got a lot of different areas to practice with. So once we get proficient with that, then we move over to the surgical skills. And that's where we start getting all of our, EJ, our jugular vein access, more innovation, surgical crikes, so if we've got a massive face injury, honestly now that's the go-to standard. As far as the days of intubating and supraglottic devices are kind of gone. If this guy needs an airway, usually we're going straight to a crike now. Also reaching out, if we can't get an IV, maybe this guy's so volume depleted, now we've got the interosseous devices. So we've got certain landmarks on the bone, we've got a little drill it in, take the needle out, and I've got access already. So I can run everything through there that I could run, blood, medications, all that great stuff. And then for the last part, combat trauma management puts it all together. So they're doing their trauma patient assessment, they're doing all their surgical skills on a realistic training model, and it's pass-fail at that point, right? So whatever the scenario might be, they get one run at it. If it doesn't go well, they get one retest, and if they don't pass, then off to the academic review board to learn your fate after that. So then we move on to Trauma 3. So this is a pretty recent addition to the course, and it's really a testament to the schoolhouse and how well they're trying to stay relevant. Once again, 20-year war, we got spoiled. We were never more than an hour away from a helicopter coming to pick you up. And guys got very complacent with that, and then we started moving to different theaters. Once we get to Africa and things like that, we're looking 24, 36 hours maybe to get these guys out. And then once we got them out, where were we taking them? Not some great facilities over there. So we started with the Trauma 3 with the prolonged field care. And this is just teaching guys, some of the stuff we don't really think about. If I've got a patient that's unconscious 24 hours, then my job just came a lot harder, right? So just nursing skills, rotating this guy, 45 minutes for a pressure sore to develop, right? So I'm sitting there, I don't have the fancy bed that, the air beds that do it for us, so we're in there rotating this guy, we're putting, chapstick, we're brushing their teeth, all that stuff that gets overlooked. Go over a lot of tactical combat casualty care. TCCC's kind of become the Bible for us. Developed, early 2000, Pat, I think, when it first started coming out? And then now it's gone DoD wide. And basically, we're giving everybody, most guys remember Combat Lifesaver, and that became a lot of, it became just, guys starting IVs. I would work in the FSTs in Afghanistan, and they would come in from a conventional unit. They're still bleeding, not breathing well, but they've got 2 IVs started, and they've got clear fluid running. So we're like, all right, cool. We need to work on this. So TCCC came out and really kind of leveled things across the board. Tourniquets became huge. Tourniquets are first line now. If you see a good amount of massive bleeding and I don't have time, he's getting a tourniquet because I can always downgrade it later, or if it was bad enough, it's going to stay on. So with that, we looked at the big 3, extremity hemorrhages, airway, and chest injuries. That was our big 3 that guys were dying from. And now, the past years, almost 0 casualties from compressible hemorrhages, anything that we can actually get a tourniquet on. In the soft community, we had 0 airway deaths in the past 2 to 3 years. And then our chest injury complications is down to almost next to nothing, I think less than 10%. So it's been working out very well. With this also, after the end of this, these guys take their advanced tactical paramedic test. SOCOM-wide test. Every 68 Whiskey 1 has to be ATP qualified. So, and then the guys head off on their rotations. So they'll do 24 days. Currently we have 5 training sites. And once again, these are all civilian hospitals. And if you notice the locations, very high volume, good places for medics to train because they're getting a lot of customers, right? And we're about to have hopefully we'll get another site opened up shortly in St. Louis, which should be another good high volume site for them. For half of this, those guys are on advanced life support, ALS ambulances. And for the second half, they're split up through the hospital, and there's how it's broken down. 72 emergency department, 24 hours of surgery anesthesia, 36 in the burn ward, 24 in OB and GYN, and 24 in pediatrics for a total of 276 hours, right? And that's not counting their EMS rides too. So for 24 days, they're going pretty nonstop. Also, we're making them do, because as soon as they come back, they're doing their paramedic work too. So while they're there, they're still studying for paramedic. So the last section for SOCM, and this actually is the newest section, the guys come back and we're doing a 10-day bridge program to get them their National Registry paramedic. Once again, kind of dual-faceted. It just gets them, if these guys do go work at another civilian hospital, most people now are like, hey, ATP is the gold standard for the military, but if I show up at a civilian hospital and they're like, well, what do you have? And they're like, well, I'm an ATP, and they're like, I don't know what that is. So, or now we can tell them, be like, well, I'm a National Registry paramedic. They're like, oh, okay, cool, we can start working with that. So it kind of helps them out with that. And this is where, too, they really start getting into their advanced problem-solving skills, because they've got maybe a different age group population that they're not used to working with, and they have to elicit all this information from them, come up with a diagnosis. So it really helps them out with that. Once again, 10-day bridge program, we're just crushing all the other, bridge programs. I went through a bridge program, it had a 50% pass rate, and currently right now we're sitting about 94%, so each class. So once again, high caliber students, and they're doing very well. That's all I got.
All right. If you guys are going to fall asleep, I'd ask you to please stand up and get to the back of the room. No. No. Right. So I'm Sergeant First Class Patrick Buckles. I'm coming up on 18 years here this December, so 2 years out from retirement. I've requested to come back here because I like teaching, and I figured why not come back and help teach students before, I get out. So I got surgery anesthesia, exactly what I asked for, and I love it. I've been in 10th group since 2007. I did 3 years at Fort Carson as an 18 Bravo. I went to Iraq, did a couple of SIF backfills while I was there. PCS to 110 Germany in 2010. Went to Afghanistan, came back. Always wanted to be a medic, so I was like, all right, 5 years went by like that. So I put my paperwork in, got it approved, and then went back, PCS for a year, became a medic. One of the hardest things I've ever done. Super rewarding, though. Went back to my same team, senior medic, went to Afghanistan. So thankfully, I was able to get a deployment and use some of my skills, which is nice, right? And then kind of just worked my way up through battalion med, worked at a TSOC stock year, so I was in charge of all of Eastern Europe. And while I was there, I tried to do something good, for the unit and for us. So one thing I saw was, all those countries speak different languages. So, it's equivalent to Florida, Georgia, North Carolina, South Carolina, but you all speak different languages. You kind of do, right? So I saw that and I was like, well, that doesn't make sense because we all speak one language in medicine. So let me standardize that. So that's what I did. And I actually put something together to standardize medicine across all these countries. So when they're handing patients off to other countries, sure, there's a language barrier, but they can still talk medical and understand what's going on with the patient at hand to get that better care. So that's one thing you may see out there if you ever go to Eastern Europe. You may see my picture or name up over there, at least up in the Nordic countries. Yep, so that's me, and that's my career. It's been fun, and thanks for having me here. So we got 3 months of the course over where I'm at, and so in Mike's realm, it's basically trauma-based, and there's a little bit of clinical in there, but heavy trauma, right, because that's what saves lives on the battlefield. So when they get to us, we get all the sexy stuff, and it's really cool. It's really nice. So first thing, this is going to go in order of how these students go through our course all the way up to the end. So the first thing they get is 2 days of physical therapy. For me, this is extremely important, and I even tell my students that, not because just the physical therapy aspect of it, but the whole kinesiology portion, because these guys, and you guys all know this, right? You push your body to the limits when you're on a team, right? We're wearing kit, we're doing long movements, and you want to be the best. So, some of you are probably in the gym trying to do that and hurting yourselves. So what's really good about this is you learn taping, you learn some simple splinting techniques to keep these guys in the fight, which is really nice. It speeds up recovery times, and it also builds trust with your teammates too, because some of the stuff is placebo, but it still works, right? This is a nice example that these guys have here. This is a cervical spine guide example. These guys can print this out, and we have what's called the LMS. It's the learning management system that is developed only for our students and cadre. I still have my login when I was a student going through, and all the students will have access to this stuff for the rest of their careers, which is really nice. Every single PowerPoint they learned with cadre notes, and all these printouts and examples, they can have all this stuff. Burn formulas. Some of the classes are done in audio so they can listen to them and reteach themselves or refresh themselves, which is really nice. So this is one of the examples I put up there, just something that they can print out and laminate and have this and take with them anywhere they go. Takes all the guesswork out. We only need to memorize emergency things for emergency situations, not stuff like this. So cervical spine, shoulder, lumbar spine, hip, knee, and foot and ankle. Those are the main things that we typically see out in the field that guys will hurt on themselves. With this too, this guideline right here, SOCOM funded what's called a Thor program. And what that does is that's a mental and physical program that they have sponsored for us. It's getting ready to be big Army wide. It's a great program. Since guys are hurting themselves, one of the typical things is going to be shoulder surgery. So these guys will get shoulder surgery because they need it. They're finally able to take care of themselves. But what comes with that is physical therapy. So we get top-notch master's degree level. Some of these people were on collegiate teams, college teams, some NFL, and they'll come and they want to help us. So they get paid. It's a big contract. And they'll come and they'll do physical therapy. It's phenomenal. They'll take what's a typical 6-month recovery time and they'll shorten it to 2 to 3 months. They double it. And these guys they're good to go. They're not 100%, but they'll be 80%. Well, then we have an athletic trainer, and that's the person that takes somebody who's graduated physical therapy, he puts them a training program together, and we'll walk them through it. Because let's face it, when we're done with physical therapy, we're going to try and push ourselves to get back even faster. But typically, guys will hurt themselves only to go backwards. So we get the athletic trainer there to do that for them, and they're side by side with them in the gym. It's a really great program. Then we'll get a strength and conditioning coach. Now this person, the one I had at 110, this guy was an Olympian stand-in for the disc throw. Great guy. Also taught at Colorado State University's football team for several years, I think 5 or 6 years. So again, we get top athletes coming in here and teaching us how to be the best. So that's kind of like the package deal. And at the same time, we get the mental aspect too, so we'll get behavioral health involved as well. Because some of these guys, especially when they get injured, they want to be in the fight and they can't be. So that kind of messes them up mentally. So we'll get them seen for that as well. So it's a really effective, awesome program. But they're the ones who designed this from the physical therapy side. If anybody's got any questions, you can throw them at me because it's a lot of stuff. So next they go into the laboratory side. This is 2 to 3 weeks here. I believe it's 2 weeks. It's really intense. This was the only thing I failed going through. I kind of got lax at the end there. It is a very long course. And I was like, yeah, I got this. What I didn't realize is this is learning anatomy and physiology over again, just at a cellular level. So it was pretty tough. As you can see, just some of the names up there under parasitology, well, it's a mouthful. So yeah, they're staring in microscopes all day. It's very mentally intense. They get a guide, which is really nice, and the instructors are incredible. But a lot of things that they're covering are what's up here. And then they can keep that reference when they go on somewhere. And on every team, what we get is, it's called a tack set. It's a bunch of Pelican cases, and inside we have a microscope. We have a centrifuge. For some of you who don't know what that is, you put your blood in there and you spin it. So you can run tests on it. We have a rocker in there so our blood doesn't become stagnant and coagulate. What else? We have a lobster pot in there for sterilization because we learned sterility techniques. I mean, we really have everything in there to be self-sufficient. We can have our own lab and everything. Yes, sir.
Are they still teaching gram stain positive?
Yes, sir. Yes, they are. Yep. We're doing smears. We're doing everything. Yep. And at the end of this block here, everything's done on the computer now. Everything's tracked on the LMS because I was going to mention it at the end, but before I forget. So as Mike was saying, we've really partnered with all these colleges because for the longest time, one of the biggest excuses was, we can't credential your classes because even though it's the same, the wording of the class isn't the same as what ours is in our college, that doesn't make sense to me, right? So now we're working with them and we're getting our class names to match theirs through U-Shoes. And now these guys are going to graduate. When they graduate Mike's side, they get an associate's degree. And just recently, I think we're on our second class now. This will be our third class actually coming up, where when they graduate from us, they have to do a few requirements at the end, and they get their bachelor's degree through U-Shoes and a bachelor's of science, health science, which is really nice. Yep. Yeah, so it's pretty nice. I mean, this is a one-year course, and they're entering with nothing, and they're leaving with a bachelor's. Yeah. Yep, so this is everything that they do. And at the end of this, there's like 50 microscopes set up. They got to go in each one, and, they have to be correct and pass with a 70%. So diagnostic imaging, so we're getting into the ultrasound stuff. A lot of this is pretty awesome stuff. As I believe somebody was saying, the X-ray machine we have, it's a mobile one, so it's just on some wheels. It's really small, but it takes images just as good as one you would go to the doctors and get. It's really nice. Everything's computerized, so you take the image. It's in a screen just like this. It's stored in there. You can hook a thumb drive up to it. You can burn a disk, and you can send that stuff off. It doesn't have Wi-Fi capabilities, but again, you can burn it off, and you can send that stuff off because we deal with telemedicine. They learn that in trauma, in the trauma side. So you can send images off to whatever doc you can get a hold to at that time, so he can help you, win your scenario. Yes, sir?
But you don't yet have in the field MRI or CT?
We do not have that, sir. Nope. But one thing we are going to start having, this is very new, SOCOM's going to start funding for all groups ultrasounds, field ultrasounds. So I just got done talking to Dennis about this earlier, and it's literally something I just got trained on Thursday and Friday is ultrasound-guided regional anesthesia. So regional anesthesia is taking a needle with agent and going at a point on a nerve to block that nerve's pain response. It doesn't have to be motor, but pain response for a certain area, right? So they've already been able to do that without ultrasound. We've been teaching them with a Stimuplex, but now we're going to do it to get even closer, because with the Stimuplex, we would go in and drop a lot of agent, 20, 30, 40 mLs. Now with the ultrasound, we can take that 20, 30, 40 mLs and we can do 5 to 10 mLs, right? We can be more accurate and it's safer. Right, so I literally just learned that Thursday, Friday, and then we're going to start implementing and teaching that on their next class starting in December. So it's going to be really cool. And two of the things that SOCOM may fund, or they will fund, and I think it's going to be group dependent on which one they want. One of them is called the Butterfly. It's about $2,000, and it's almost like a 2-for-1 type of probe. And what I mean by that, because each probe has a different depth. So this one is a 2-for-1, but it's one single probe. Cool thing is you can hook it up to your phone. So you plug it in your phone, it's got an app, and you got it on your phone right there, which means you could screenshot, you can save imaging, and you can just send it to a doc, right, versus the other way around. I mean, that thing's bulky, right, that mobile one. There's only one per battalion, and they're extremely expensive. Not to mention they don't even get maintenance half the time, and you never use it, right, because all the radiation that comes out of that x-ray, right? So this going to this ultrasound is just going to be phenomenal. It really is. The other one is called the V-scan, but it comes with a tablet. It's going to be more pricey, but it's a dual probe. It's two-sided for the curved linear and the linear. So it's pretty awesome stuff, and we're super excited to be teaching this. Yeah. So that's coming. That's super new. So you guys are one of the first ones to know that's coming up the pipeline here in the next month or two. Yep. So on the ultrasound, these are the advanced things that we do. So before they were learning the EFAS exam, so bleeding in the box, if they're going to die, what can we do type of thing. So for this one, we just do musculoskeletal. We teach them that they can look for fractures and stuff when they don't have the x-ray in the field. Soft skin, and then we used to do testicular when I went through. I know it sounds funny. But there was a reason for that. They stopped it for whatever reason. They still talk about it, but they don't actually physically do it. But we physically do these in the course. Dental, this is a 2-day block. We actually get dentists to come down. They're military dentists or surgeons that come down. They run through their slides. There's a test at the end. They're actually doing these shots. I'm sure you guys did this. Yep, okay, fun stuff, right? Especially when you come super orbital and it comes out the face and squirts in their eyes. Yeah, fun times on that one, right? But really, I don't think anything has changed on this. It's still just you're shooting agent in there. You're trying to, either get a zinger or not, and you're in the right spot, put a bunch of stuff in there, and you're done.
For extractions, you still use some 150s and 151s?
Yeah. Yeah, the cow horns. Yes, sir, yeah. And what's great, so, not a lot of people get to do this, but when I run on rotation, I was actually able to pull some teeth, which was pretty nice. Yeah. It's actually not that hard. It really isn't. I thought it would be a lot harder, but it's not.
It's better on them than us.
That's true. Yeah. Yeah. So, yeah, 2 days of this, they test out, and then, they keep going. By the way, there's not really a high failure rate for this, for any of this stuff that they go through on this side. They're pretty good at studying at this point. We do sometimes get some failures on this, and they'll retest and pass. Same thing goes with the labs. Other than that, they really don't fail anything else. It's probably instructors. Okay, so then they go into veterinarian medicine here. It's really advanced, but it goes into all the different types of livestock that are out there. One of the vet staff that we have, she's civilian. I believe she's contractor. Her name's Tammy. She's phenomenal. She has her own farm with animals, and she has her one day where she takes all the students out to her farm, and they're doing nothing but physical exams and administered medications to all of her livestock. So it's pretty cool. They get hands-on for a half day. They also, so that's the first half of that day. And then the second half, they'll do a slaughter and preparation, which is pretty nice. And they'll usually get a lamb and a pig. And they're learning how to put the animal down humanely, and then how to preserve it. And, and they'll gut it, skin it, and then they get to keep the meat as well, or they'll have a barbecue.
It used to be dog labs, now, when I went through it was goat labs. Are they still using?
I am not at liberty. I cannot confirm or deny.
I meant to say at the beginning of the program, it's my fault. Some of my slides were censored, and when SOCOM agreed to have these gentlemen come down, there are certain topics under today's world that are off the limit. However, afterwards, they'll be joining us over there, and you can have your own discussion.
Thank you very much.
So, so they do the slaughter class. It's pretty nice. We just did one recently because we had some guys going away. We had a guy get accepted to the PA program. He's taken off, I think, in a week and a half. So we had our own little cadre slaughter class, and they got the grill out yesterday. I wasn't there. So they do preventive medicine. So there's the horses. Tammy has her horses out there, which is pretty nice. They also do they'll put an email every class. If anybody wants to get their dog seen, anybody can bring their dog and get a free physical exam and medications administered. It's pretty nice, and it gets the students the reps they need. And if nobody comes, it's not a big deal because they're typically working on the military working dogs. The third bullet over there, common diseases and conditions or ruminants. I don't know if that gives that away there. Those are for certain types of animals that spit their food up and chew it again. So this is my block. So all the other ones, there's different support cadre that'll teach those because those are support MOSs. And then for the surgical management, that's some SOIDCs, which are the Marine Navy guys, and then 18 Deltas. We got contractors that were prior 18 Deltas, SOIDCs, and GSs as well. So basically, this sums up, our block right here is going to sum up the entire course because they're going to do their clinical care at the same time that they're doing their management, right? So scenario plays out, right? Our human patient role models have been injured. We will fix them. And at the same time, they're doing their critical care nursing skills for about 4 weeks. So it's pretty long. But that's why I love this block so much because we're doing clinical medicine. They're actually giving medications. We're actually doing splinting and casting, passive range of motion, physical therapy. We're doing literally everything. All our lab studies. Yes, sir.
And this is all during their clinical proficiency training?
No, this is all during the surgical management block.
So this is, in my day, we'd go to one of the med centers. So this is done in the classroom, or this is done like the OJT?
This is done in an OR. Yep, I can get into more detail after. But yeah, so I can get into more detail after.
Okay.
But we have 6 ORs. They're not all run at once, but we have 6 real ORs, and we conduct all of our classes and business inside there.
And these are different military medical centers?
No,
In the classroom?
this is ours. Yeah, we have 6 ORs at Special Warfare Medical Group. Yeah, JSOM. Yes, sir.
Getting a little confused on who's getting trained. Talking about the 18 Delta course still?
Yes.
And you mentioned a 3-year course.
No. 3 months.
3 months.
Yes, 3 months. So it's a 12-month course. Mike's is 9 months long. For the SOCM, Special Operations Combat Medic, that's the basic medic for SOF, your Ranger Medic, CA, your Civil Affairs, PsyOps, all that stuff, with your Whiskey 1s. Then they graduate that. The students either can continue to be 18 Deltas or the SOIDCs on the Navy side, Marine side. They continue on and finish my block, which is the 3 months. Yep, and then that's 12 months, and then they graduate. Yep. So only the ones that graduate my portion will also get that bachelor's degree. The 9-monthers, they get the associate's degree, right? And then that's all trauma. All right. So yeah, so in this, right, they're getting other clinical skills. We're teaching them surgery, sterility, and anesthesia. And it's IV anesthesia. We don't do any gas. We don't do anything. It's all IM. And we stick to some pretty basic drugs. So our Versed, for those of you that know your drugs, ketamine. There are, let me see here, some Dex. I don't know if you guys remember Dex. Probably do. Stayed off for some pain control after surgery. And then ketamine. We do some propofol, intra, surgery, and for takedown, and for emergency. So we use Versed. Yes, sir. So we're not too worried about that, only because, so the studies with ketamine for that adverse reaction when you come out, typically it depends on how you go into your dream, that's how you're going to come out of your dream. So a lot of that stuff with the whole ketamine and people coming up and saying that's the worst dream they ever had, they were living in a nightmare. Well, if I just got blown up and I'm getting shot at and you give me not enough ketamine and I'm going to have a bad trip because I went into a bad dream because I just got blown up and shot at, I'm going to come out of it getting blown up and shot at, even though I'm still not in that scenario.
30 years ago, ketamine was for animals, or if it was on a street, it was special K.
Right. Yep. Yeah, so now it's one of the safest drugs that is out there, and that's why we carry it. That is our go-to. You can give it IM, you can give it IV. There's just a small window that you have to stay out of in case of that adverse reaction. So you either give not enough to take the edge off so they can function, or you put them to sleep, essentially. That's how you do it for that. But what's great about it is, I mean, in a pinch, if I mess up and I give too much, it's completely fine because it doesn't affect the airway whatsoever, which is typically what we're worried about. And it also doesn't decrease the blood pressure. It'll actually raise it slightly, which can be a bad thing pending. But it's super safe because there's really no complications with it whatsoever. Yeah. Like morphine, if we give too much, they stop breathing. Now we got a whole nother issue. So we actually completely went away from morphine. Yeah, we don't even teach it anymore. They don't even mention it in his block, which they used to. And the morphine auto-injectors, those have been gone for a really long time now. Yep. So, yep, so 4-week block, right? So 1 week they'll get debridement. They'll see the healing process into the second week when they do their DPC, their delayed primary closure. And that doesn't mean they're going to do it, right, pending the wound. And if not, we'll show them some techniques, but it'll just close by secondary intent. If they can't close it, we'll try and close as much as we can. And then there's another week that passes by, then they can see how the healing stages has progressed even more, and then we get into amputation where we actually do a full amputation, and then we're done. Yep. And they're graded on all that stuff. So we don't grade our students on surgery. They're not surgeons. We don't expect them to know. That's all the things that encompass all around that, right? The blocks, they do a block every time, a regional anesthesia block. So, right agent, labeling, sterility, all that stuff. So plenty of chances for them to fail. We make sure of that. But they don't. It's a good time. And lastly, I'll touch, it's not on here and I don't know why, but one of the biggest things we teach too is compartment syndrome and how to do a fasciotomy, which is a big deal, and it's a limb saver. So we also teach them, they're graded on lower limb, but we do teach them upper arm as well, right in the forearm. So we teach them that. That is a graded event now. And then after that, they go into their rotation. It's 4 weeks, right? They got to do 240 hours, and unlike Mike's rotation where it's strictly trauma-based and they go and do EMS rides, on this one they don't. They're strictly in the hospital the entire time, and basically what you saw them get trained on, that's what they're going to do, right? So when I went, I spent a lot of time at physical therapy because I knew the issues. So, because I was a Bravo, going back as a Delta, I was like, yeah, I was always seeing the medic, either wiping noses and handing Ranger candy out, or he was doing some type of physical therapy, sports medicine type of thing. So I spent a lot of time in physical therapy. That's when I pulled some teeth, and I spent a lot of time in the ER, which was a Jerry Springer show down at Fort Hood. A couple stories down there. It's pretty funny. But, yeah, it was pretty good just, taking care of kids, which is a big thing that, we were doing forward, which can go, no-go your mission. And, yeah, it was a really good time. But, yeah, so they get a trauma rotation, and then they get just a clinical rotation. And then they come back. After they come back from that 4-week rotation, and they've graduated at that point, and they out-process, and then they go to 4th Battalion and start the rest of the Q course. So for the medic side, they go to selection. They get selected. If they're going to be a Delta, then they come straight to the medical course immediately, and they do their 1 year of training. Yeah, so when they graduate, typically all their buddies are already done and graduated. Yeah. Yeah, same for you guys, right? Yeah. Yeah, and that's pretty much it for my side, and I think Mike's got some more he's going to talk about here.
So once course is over, we got to maintain, right? So we have a couple courses made to maintain, then we got some built in. You're able to go on an MPT, either a two-week, 1 month rotation, usually military treatment facility, but we've got a lot of civilian hospitals we work with also. So the one, our 68 Whiskey 1s and AT Deltas have to go to SOCMA C. 2-week refresher, very trauma focused. This is also the place where we get back, one of the great things about it, we have all the organizations come together, and each group, we'll get a representative from each group to do a lessons learned, so whatever they saw. So we get some 160th medics, hey, I did this great thing, or the Rangers did this, so we all get together, really talk about lessons learned, what new equipment's coming out, and new medications, things like that. So it's really good. So our newest one, though, SFMS refresher. So if you got an 18 Delta now, 18 Delta SOIC or a SARC, it used to be, it was 2 years I had to go to SOCMS, and then the next 2 years I had to go to SFMS refresher. So SFMS refresher now has taken over the whole thing, and now a 3-week course. Well, it's still a 4-week course. It's 2 weeks of break, and then we finish our first. So we're still getting our trauma, but at the end of that, then we're kind of going through Pat's section again. We're doing all just surgeries. And now we've added in, so we're doing a lot of crush surgery protocols. We found out, throughout our wars in Afghanistan, one of their techniques, they started dropping houses on guys. So we had a lot of extractions, a lot of crush injuries, things like that. So we really started adding up to that. Chemical agents, is kind of the hopefully not the war of the future, right? But really reaching into that. We review our regional anesthesia once again. And we really started, like Pat was mentioning, we really started looking at regional anesthesia, because rather than taking a guy, hey, I twisted my ankle up in the mountains of Afghanistan, what do I do with this guy? Do I give him a bunch of drugs and snow him out, and then I have to carry him and his stuff? Now we're able to, hey, I can do an ankle block, I can do above the knee, we can block this guy, maybe he can walk, the rest of the way on his own, and I didn't have to reach into narcotics. Yeah, absolutely.
Yeah,
Yes.
so the biggest thing too with those regional anesthesias was the mental side of the pain. So they're doing a lot of studies with the guys that experience pain, and they're having a lot of PTSD later on down the road because of that pain, to the point where they won't do certain things because they don't want to feel that pain that they felt prior to. So that's one of the biggest reasons why they want to push the regional anesthesia stuff, is because you can block. I mean, we learn how to block the entire shoulder all the way down to the arm to the hand. Same thing, basically from the very top around the hip, we can block the entire leg, and that person can still function. Because again, we can do it to the point where we only use enough to block the sensory, the pain, but they will still have some motor function, so they can still move. It feels funny, but they can still function. So that's one of the big reasons too why we really want to start pushing for that regional anesthesia.
VA needs to learn that.
I'm sorry?
VA needs to learn that.
Yes, they do. They really do. And I think they're getting better. So I was at Womack. I did my rotation at Womack, and the pain guys there, they have a strict pain clinic. And what they do is they try and take pain away from guys so they can even start physical therapy, which is another big thing right they're starting to do techniques to implement to do these regional blocks, just so guys, they'll get the block and then they'll go do physical therapy. So they can actually start to get better. Yeah, it's really good stuff.
And then finally, we kind of reach into telemedicine. Telemedicine's become huge for us. Usually, so we'll be middle of surgery or getting ready to start a surgery. We can just dial up the phone. Usually, we're lucky enough. There's a full-board trauma surgeon down at BAMC who always likes to play. And so I've got this trauma surgeon on the phone. Kind of intimidating when the first couple times you do it, but just get those reps out of the way. And I can tell him, be like, hey, sir, this is what I got. This is what it looks like. This is what I'm thinking about doing. And he either comes back, he's like, no, you're an idiot, don't do that. Or he's like, yeah, sure, it sounds good. I'll help you out, I'll guide you through it. A lot of other good stuff too. We're able to, if I can take a picture of something, a lot of times dermatology, right? I don't know how you guys were, but I'm not very good at dermatology or anything. I'm like, yeah, sure. Yeah. Now I can take a picture. So if we're out in the jungle somewhere, I can take a picture, I can send it to a dermatologist. There's one 24 hours. Within 24 hours, if I email that off, I'll get a response back from somewhere. There's always someone on call in the nation. So, and that's with anything, dermatology, ophthalmology, all that great stuff. Derm's probably the one that gets used the most, and then of course our trauma surgeons after that. So, and
Yes, sir.
I was just wondering, with all that training and experience, in terms of training, how far away are you from being certified PA?
So, a lot of people, they'll just flat out say that you guys are like this close to being a PA. The thing is, and if you ask anybody who comes to the schoolhouse and teaches us, they say we're like trauma gods. And, when you're done after that 9 months, you really are. There's nobody out there better than us in trauma. But it's trauma, right? How much trauma did you get going through your PA course? Not a lot. It's all clinical, so it's completely different. And I would say you're close. You can learn the material faster than somebody who didn't go through our course to learn medicine, right? So we're well equipped to come into the PA program and just crush it because we know how to drink from a fire hose at that point. Yes, sir.
Correct me if I'm wrong, there are some pilot programs right now for maybe 18 Delta convert to a PA in 1 year that you can.
Yes. So,
I know there's three people.
yeah, so the wording of it is not that great because it's like a transition. So you think that you've done all this time and you can just get out and transition over, but it's not. It's the opposite of that. So it's a chance for you to come back and be sponsored to get paid to go to the PA program, the IPAT program. But you owe a debt to the schoolhouse when you come back for 2 years upon graduation, and you would teach there. And then you can go back to a team, and you can be an 18 Delta on a team with a PA certification, but that's it. So, that sounds great, and it is great, but a lot of guys want to do the PA route because, let's face it, we're underpaid as a Delta on a team for what we have to do, the amount of stuff that we have to learn, and the upkeep that we have to have. The certifications to every 2 years, all the new medicine coming out, the new studies, we constantly have to stay up on our skills. Nobody else has to do that. When I was a Bravo, we would get like a new sniper system every 2 years, and it's like, learn this, and somebody would come out and teach us, and that was it. Or a new optic came out, so really easy, which is why I reclassed, because to be honest, I got bored as a Bravo. But yeah, so that's my opinion. A lot of guys go to the PA route because it's stable for when they get out, right? It's something when they get out, and it's a 6-figure paying job. Yes, sir.
Yeah, I was gonna ask, when I went through the course, we also had Navy, IEC.
Yes.
SEAL Corpsmen and Marines. Upon graduation, those fellows started drawing $600 some plus extra a month to graduate from the course.
Wow.
They still do that?
I'm not sure. I can't speak for the other services, sir. But
they-
I would imagine so. I would
Yeah.
imagine they would.
Usually with those guys, they're already, so the SEALs don't come through the course anymore. So those guys decided to go their own way. We don't have the PJs anymore, so it's just the Navy. So just the SARCs, the SYDCs are coming through. But what kind of benefits those guys is they're already through their pipeline, pretty much. So they're, like when the SEALs were coming through, they already had their tridents, they were getting their pro pay and all that good stuff. And we're sitting here sweating bullets, worried about getting kicked out every day. So, yeah.
Yeah. Yes, sir.
I was an SF medic in the sixties and became a PA in class 4. Class 1, of course, was the number 1 PA. My point is this, having been a civilian, working as a PA and a long time retired, the problem with guys when they transition out of the Army or wherever, to get a job in a state, whether it's Florida, Texas, or New Mexico, Arizona, or work those places, a lot of times you run into resistance from nursing, okay? Why don't the Army teach people to be both an RN and a PA at the same time, because they're so damn close, you know? If they did that, they would, there's 2 million nurses or something, RNs, and you might have 100,000 PAs. Guess who's gonna win in a state and get what they need to do their job? Why doesn't the Army go and join them together? They're so close.
I'm not sure, sir. I can bring it up. I'll bring it up when we get back.
About that political point,
Yeah.
it's very real.
Yes.
Uh,
No, s-
If I may, at this point, I've been given the timeout sign, kind of.
Oh, okay.
And to address that, because I'm a PA by background, I went through this, and then became a PA. Back 30 years ago, that was certainly the case, because nobody understood your background. But in today's environment, because I'm still involved with clinical research, I don't see that anywhere near as it used to be, and I think we've kind of crossed that.
Maybe it's not as it used to be, but it's still there. I can see it in Florida, I'm a Tampa, Florida. I got certification and all that when I went to Florida. Didn't work hardly anything in it, primarily because the nurses had everything tied up. It wasn't that they were any better than a PA, or any of that. It was simply political. They had the numbers. It's the numbers that matter when you're looking for a job.
Right.
And it still exists. Who can write prescriptions and who can't. Nurses start to write, nurse practitioners in New York City wrote prescriptions right away, the first ones, PAs down in Florida, they didn't write prescriptions, maybe 5 years ago they started.
Okay, thank you. With that, I'm going to close this session, but I just want to say thank you all for being here. If you have information you're willing to share with me in the future, please do. And a big round of applause for these 2 gentlemen. You saw that sign at the beginning of the training thing, through these doors walk the best medics in the world. That's them. Oh, and we're going to move any discussion so they can have the room for the next presentation. These 2 gentlemen, like myself, are very thirsty. So we're going to be in the big room down there, and please come talk with them. They got a lot to share. Thank you.